I'm very happy to be here. It's been a long journey. I'll tell you my story as we go on, but I'm very happy to be finally done with all training and boot camp and everything. So these are my disclosures in alphabetical order, except the EMD. It's not, but don't mind that. So Canada, why Canada? So Canada is the best place in the world for many reasons. One, yay, clap, clap, clap. Come on. For many reasons, the one that I first chose is because MS is the most frequent in Canada, and that was the best place to learn about MS. So because I liked MS from my early training years, I said, okay, where in the world? Canada. So that's why I moved in 2005, and I started continuing with my MS education. In Argentina, it's 1 in 10,000, so it's very rare. It's not that frequent. In Canada, it's 1 in 400 or 1 in 1,000. So it's much more frequent. But my mentor in Argentina was an MS doctor that used to see MS patients, and that's how I got hooked. So I did come to Canada in 2005. I was in London for 2 years and then moved to Ottawa. But for some crazy reason, my husband appeared, so things got further complicated. So we got sort of serious and got married and then said, okay, I'm staying in Canada for the long haul. So unfortunately, I had to go through residency again. So 5 more years of residency when I had done the whole training, but oh well, whatever. What doesn't kill you make you stronger, right? So 5 more years, 10 winters, which were rough. Less so, the last couple were, well, you get used to the winter, and 1 baby later, so I'm here to stay. So Canada is my home. I became a Canadian citizen in 2012, so yeah. It's the best place in the world, right? So we're going to talk a bit about early treatment, okay? So I'm sure every time that we talk about early treatment, you want to know pros and cons, why we tell you to start treatment early, and with all the sort of implications that has, right? So this seems like a bit silly. So you start treatment when you're 100% sure or 98% sure that you have the right diagnosis, which sounds kind of obvious, but it's not, because it has a lot of implications, right? So employment, life insurance. If you want to get life insurance, you probably won't have you will be declined because you have MS, which is a chronic condition. So it has a lot of implications in the long run. We sort of think that at the diagnosis of MS, we miss diagnosing MS in 5%. So that's pretty good, 95 that we're 100% sure that you do have MS. But there's a percentage, 5 roughly, that we are not too sure. And usually we overdiagnose MS. So we kind of, oh, your scan looks funny, or maybe symptoms. So we usually overdiagnose it instead of underdiagnose it, which is kind of makes a big difference for young people that are going through a long chronic disease. And on the flip page, so undiagnosing someone with MS is also very traumatic. People that had sort of the stigma or the label of having MS for many years, then you tell them, oh, you don't have MS. So it's a big also, they can be a big issue. You can lose your benefits. You can lose sort of support in the community. No, okay, you don't have MS now. What's wrong with you? So it's a big issue as well. So when do we normally start treatment? So I'm not sure in the audience, now we know that after the first treatment, the first attack, we know that that's when we should start treatment to prevent further attacks and to prevent further issues. And that's called, fancy word, clinically isolated syndrome, or CIS. Or we usually recommend starting treatment after second attack or third attack, obviously, or with 1 attack, and sometimes we do MRIs to follow you. So if the next MRI shows more lesions, we're kind of, oh, you probably should be on treatment after only one attack, and the MRI looks like you're having more lesions in the MRI. So we know from 25 years of studies that the early attacks are going to dictate how good or bad your MS is going to be. And usually in the first couple of years, 2 to 5 years, is where the attacks have the most impact. And that's why we recommend the early treatment. Because if you have a severe attack at the beginning, chances are that you're going to have bad attacks in the future. That's not 100% sure, but most of the times, MS behaves in a certain way from the get-go. And that's going to dictate also how you are going to do in the long run. Which is good, because we know that if you hit it early and hard, you're going to do better in the long run. Sometimes hard to understand why, but... So this is a graph. I'm not sure if it's a bit... so it tells us what I was saying before, so that the number of attacks in the first 2 years. The first column, it's in EDSS. Do you guys know what the EDSS is? The number that we give you every time that you go to the clinic? Yeah? Are you obsessed with the number? No? Good. It doesn't matter. It's all for us to... Doesn't matter. It's just a number to have a more objective assessment. So EDSS of 3 and EDSS of 6. EDSS of 6 is using a cane, and EDSS of 3 is you have some issues in in your sensation, in your walking, but it's not too severe. So if you have one attack, you're going to have more time until you reach that sort of milestone of disability. And in the in the blue and in the red, you're going to see, so the more attacks you have, do you have a pointer here? No, eh? Yay. So does it translate in the page? No. Yeah? So here, so if you have one attack, you're going to take longer time to reach these milestones. And 6, you're going to take longer. Obviously, if you have 2 to 4, you're going to shorten that lapse of time. And if you have more than 5, obviously, the time lapse gets shorter. So we know that treating MS early on, it's advisable because we have a lot of information from the first trials with the first MS drugs. So Avonex was the first one to test, after having a first attack, you go on these drugs and delays the conversion to MS and to have more attacks. So you postpone the attacks that will come in the future. So we have that, we have that information for that clinical trial. So one of the newer drugs, teriflunomide, is probably going to be soon approved for CIS after having one attack. Currently, if you had one attack, you only can go on injectables. But that's probably in the next year or so, you can choose oral medication as well, which is a big deal for newly diagnosed patients. Oh, daily injections or every, often injections or a pill, that's a big thing. So we also have a lot of experience from early MS patients. So we know that even without having many attacks, MS is a very sneaky disease and sort of affects other domains. You can have memory problems, you can have eye vision problems without having a clear-cut attack, and your brain can shrink faster than if you didn't have MS. So those are compelling sort of supporting evidence to say, treatments, there are available treatments, so you probably should go on treatment early on to preserve as much as you can. And we know also from 500 years of people studying MS that the damage occurs early. Even if you don't see it, you feel well. I say, well, why start a medication? The damage keeps sort of accumulating without having any big issues, which is very scary. So other issues with diagnosing MS. So when you come to the clinic, it's very traumatic to say, okay, you have MS, this is a chronic condition, and we cannot tell you what your prognosis in the long run is going to be. That's a big issue. Even if you have cancer, right? They tell you, oh, this is a good cancer, this is a bad cancer, you're going to have 50% chance of dying, getting better with the chemo. MS, unfortunately, we don't have the tools to say you're going to do better than the other person, you're going to do well, bad. So that's a very strong, that's a very big thing when you get diagnosed, right? It's not linear. Even though you can have a mild attack, and the second attack could be really, really bad and can be leaving you with residual symptoms. So sometimes people say, oh, but my first attack was very mild, I recovered completely, but maybe the second one is not going to be as good and you don't recover as well. And patients don't like when I say these souvenirs, sounds a bit too good. So 30% to 50% of the attacks will leave you with residual symptoms. After having an optic neuritis, you can be left with color blunting, you don't see as well. If you have inflammation of your cord, you can be left with chronic pain, with nerve pain. So they're not, it's quite you're going to have them for a long haul. So the souvenirs, people, yeah, there's bad souvenirs, okay? You can have good souvenirs, but these are bad souvenirs. And benign MS, we don't know when you first come to the clinic, we don't know who's going to do well and who's not going to do well. So benign MS is a term that it's probably a misnomer. Benign MS, sure, it does exist, but it's a diagnosis, a retrospective diagnosis. So we won't know until 20 years pass if your MS was good or was bad. So that's why, oh yeah, I have a benign MS. We'll have to wait. So now we know that if you follow people 25 years, 10% of patients will have benign MS. If you follow them longer, the percentage decreases. This number is without treatment or with the earlier treatment. So that's a bit, we may be sort of, this number will go up because we know that the newer treatments are more effective. So we'll have to, in 20 years, I know for you, like you want solutions in 5 years, not in 20 years, 30 years. But sometimes we need to follow people over time to have a good evidence that works. So I find this is also a very important issue with the newly diagnosed patients, the pressure to be proactive. So your family members, your spouse, your friends are like, okay, if you don't want to go on treatment, they will say, why, if there's a treatment that can hold your disease for longer, why wouldn't you take it? We have kids, so it's a lot of pressure from yourself and family to go on treatment. But everyone is different. No one is ready to go embark on long-term treatment, and everyone gets to the point of treatment or no treatment at their own pace. I find that overall, obviously I don't have MS, but the medications have side effects that are not terrible. At the beginning they could be bad, but then you get better. So if I had MS, I probably would take the medication because I know that that's the evidence that shows us that I'm going to do better. But obviously I don't have MS, so I cannot decide. We tell patients, even if you don't want to go on treatment, we're not going to kick you out from the clinic. We're going to still see you, every 6 months as anyone. So it's important that we also tell patients, we recommend, but it's you know what's best for you. And I find that this also is very important. So sometimes people say, you know what, I'm not going to do treatment. I'm not going to go on treatment, and that's kind of empowers them saying, I'm in control of my disease. I'm not going to go on treatment. But you can argue that you should, if you go on treatment, you're going to be more in control because so it's a very personal choice. Or the same thing with the diet. So there's a lot of, probably, we'll discuss that later, diet and MS. People find that if they go on certain diets, they have more control of their MS than if you don't. So that's something that you can control. And people find that, going into specific diets, that gives them an extra sort of control of the disease. So I was sort of alluding to this earlier, but when to start treatment? You need to be ready because it's a long-term commitment. It's not, you're going to do this for 2 months, then you're going to switch, you're going to stop, 5. All medications take a long time, 3 to 6 months at least to fully act. So there's no point in starting it, stopping it, and then restarting or switching around. So you have to give the medication chance to work. So whenever you're ready, that's when you should start. Side effects, whoops. So the side effects obviously are very scary, but we know a lot about side effects. With the newer medications, we know less. But with the older ones, we have more than 20 years experience of the side effects with the older drugs. So they're manageable. And 2015 is a good time to have MS. There's 10 approved medications for MS. Obviously, having MS sucks, right? I'm not going to say, oh, yeah, MS is great. It's not, but it's a good time because there's a lot of things going on. There's a lot of research. There's people like 10 years ago, they only had a few options, right? So now we have 10 options, small guns, big guns, like medications that you can take orally, injections or infusions that you just go and don't have to worry about in the meantime. So there's a lot of things going on. And research, so that's very challenging but very exciting. So we're testing all sorts of different agents and drugs, sometimes not related to MS. We tried medications for acne, antibiotics, medications for cholesterol, and they may work in the end, but we don't know. But it's and with the bone marrow transplant, with the stem cells. So always we're trying to find something that may work. So that's very, very encouraging. And this, it's a bit of, I find like in Canada, MS being so frequent, there's a lot of public awareness and social acceptance. You say, oh, you have MS, so people are more, the employers are more open to, to help you. In other countries, when it's very infrequent and rare, you get you are lost alone in the middle of all these MS journeys. So now in Canada, fortunately, it's a big since it's very frequent, everyone knows someone with MS. Neighbor, friend, family. So doesn't seem, for you may not, feel like you are visible, but you are. The MS Society always tries to help you. Obviously, funding is an issue, but always we try to help you as much as we can. So there's different tiers of treatment. So the first-line treatments are, the older drugs, probably you are taking one of those, Betaseron, Diavonex, Ribifa, Copaxone, and the newer oral medications. The second line, which means that there are stronger medication, the Gilenya, Tysabri, and the Lemtrada. And third line are the Lemtrada, the Mitoxantron, Cladribine, and cyclophosphamide. So these medications we use they're chemotherapy agents, so we use for really, really aggressive types of MS. And sometimes we use that before starting any of the first-line treatments as a boost, stop your disease, and then you transition to a more tolerated medication. But we still use this a lot. And experimental therapies, we're doing all sorts of research with different drugs. These ones are probably going to be in the market in the next 2 years. The BMT, the bone marrow transplant, that's been going on for the last 12 years. In Ottawa, the Ottawa group is the one that has done, I think, 40 transplants so far from people around the country. And the results are pretty encouraging. Obviously, it's not for everyone. Has a lot of side effects. It's 5% chance of mortality. So, and then for 1 year, you are off work. You relocate to Ottawa. So it's a big commitment and not for everyone. But that's an option too. So if the first line drugs don't work, you go to the second line. The second line don't work. You go to the third line, and these are kind of the bone marrow transplant. It's a rescue treatment, if you will, for bad MS. We're doing now the stem cell therapy. There's a lot of hype about the stem cell therapy. We don't know if it works. People go abroad and may have stem cell therapy, but it's not strictly controlled. You can get infections, and we actually don't know if it works. So there's some preliminary evidence that say that may work, and actually we're starting a trial with 20 patients. Ottawa and Winnipeg are going to be the sites recruiting. We have 2 patients that started in the last month with this, but it's not it may not work. So sometimes people say, oh, I want stem cell research because this is, that's going to cure my MS. At this point, we don't know. Looks very promising, but we don't know. So going to to the big choice of medications. So in the smaller circle here are the ones that have been sort of approved and are available for treatment. And look at all the other ones. They're like in sort of earlier stages, first phase, second, and some there have like funky numbers. They don't have names yet because they're so preliminary that they're all kind of witchcraft, medication, but they may be, maybe one of these is going to be the new best thing in a couple of years. So what I was saying before, it's a very good time to have MS now. Oops. So not everything that is new is great. So the old medications and new medications have different side effects and different issues. So the older medications, we know from 20 years of experience that they are safe, they're being tolerated, and we have a lot of experience worldwide that they work and that they, besides the mild side effects, they're tolerated. The newer ones, we are sort of starting to know what's going on. There's some side effects that we've never seen in the other MS drugs, like this PML, this brain infection that I'm not sure if you guys know. It's a very bad infection if you get it. So certain drugs are being associated with this brain infection. Some of the newer agents, now there's a third case. So they're popping. We having those issues with the newer ones. It may stop there. We may not find anything, but we need more time to sort of see if these are safe or how safe they are. And also, so we don't know the safety of sequencing medication. So if let's say that you got one of the chemotherapy agents because your MS was terrible at the beginning, you may not be eligible or would not be advisable that you take one of the newer ones because that could put your risk of having this brain infection or other infections much higher. So also the sequencing of the treatments, we don't know much. What's the best sequence, 1, 2, in which order we do it. So how do we assess if the medication is working? So that's where we don't have a correct answer to that, and it's a moving target. We try to look for tools to say, okay, this is going to be the best way of following you over time, but we don't have an answer yet. But basically, it's threefold. So your exam, every time that you come to the clinic, we examine you and we say, okay, you are the same than 6 months ago, you're a little bit worse. So based on the exam, we know where you stand, that number that I was telling you, the EDSS. So, and then we always ask you about relapses, right? So do you have 1 relapse, 2 relapse, no relapses? Your relapse was mild, was severe. Do you need to get steroids? Do you need to be admitted because the relapse was really bad? And we know now that the MRI is also important to follow you. So sometimes you could be doing very well. Clinical exam is unchanged, no relapses, but then the MRI, sneaking up, you have new lesions compared with the previous one. So depending on how much activity you have in the MRI, we sort of are more concerned or not. And we have no consensus about, it's 1 lesion acceptable, 2, 3. So we're getting sort of more, trying to get more experience about that because we don't know yet. And this is basically the same. One thing that we also always want to ask, how are you taking your medication? Are you really taking it? Many people, if you don't ask, they are like, yeah, I'm taking my daily 3 times a week. I missed several, so the medication is not working because you're not taking it right, or it's not working because it's not working. So we always have to make sure that patients are taking the medication in the right way. And so this is the same. So this was done, the Canadian Consortium of MS Clinics is a tool that actually is used worldwide about trying to assess how your medication is working. So relapse is the progression of your exam and the MRI. So if you have a mild relapse, that's a bit concerning. If you have a mild relapse, but then your exam shows signs that you're worse from the previous time, that adds up in the concern. And if you have a relapse, your exam is worse, and then your new MRI shows that you're having more lesions than the previous one, that's very concerning. We don't know exactly now how this plays out. One mild attack and one lesion, is that concerning? Not. It's complicated. Some people have, and we have not standardize this, so it's kind of a work in progress. We don't know, one relapse is acceptable, a mild one, it may not be. Probably no relapse, we shouldn't tolerate any relapse, any activity in your MRI in the early 5 years. So when to switch treatment? Obviously, if you're not tolerating the medication, you're having a horrible time, you're having bad side effects, we'll stop it and think, what else can we try? Ongoing activity based on relapses, what we're talking before, the MRI, and if your exam shows signs that your MS is getting worse without having relapse that we can sort of pinpoint. And this is very important, and it's something that we are learning. Depends. We're going to switch treatment, depends on where in the MS journey you are. We may not switch if you are kind of late. If you had MS for 15 years, we may not switch. But that's very personal. So some people would do, everyone is different, so you can have early MS at 5 years, or you can have, quotation mark, early MS at 10 years. So everyone is different in this sort of journey. This probably will help to clarify. So MS in the beginning, this green line here is the degeneration. That's the damage that keeps accumulating. Here, all these little arrows here are the MRI lesions. So the MRI inflammation seen on MRIs. And these are the attacks, right? So we know that we have several types of MS. The CIS, so only one episode. We have the relapse and remitting MS, and we have the secondary progressive MS. And this category of MS called transitional MS is when you're kind of in between relapse and remitting, you're having attacks, but you're slowly getting worse. So we know that the treatments actually work here after the first episode, and mostly on the relapse and remitting category where the inflammation, the MRI lesions are very, very prominent. It doesn't work as much when the damage is accumulating and when you don't have as many attacks or as many MRI lesions, because the MS is inflammatory and it's a degenerative disease. So the treatment usually are good for the inflammation part from the early MS, but we haven't found a good treatment for the slowly getting worse, for the damage that happens with MS. So that's why the window of opportunity is an old sort of a concept that is coming back. So depending on where you are here, we have more time or less time to give you less aggressive or more aggressive treatment. So if you just started on having one attack, we're like, we can start with the first-line treatment, see how you do. Most people will do well with first-line treatment, but some people will have attacks, so we have to move on and give you something stronger. Or if you are late in this sort of journey, you don't have time to go through the, okay, first line, second line. You may start with something strong at the beginning. And that's sometimes what we do. Maybe we do chemo or we do other drugs if you're late in this sort of stage, because we don't have time. We know that we're kind of getting close to where this window of opportunity closes. So that's depends on where you are. And everyone is different. So it gets us some time to know where you are in all this MS journey. So there's two models of MS treatment, and the one that we mostly use is the safe and slow approach. You start with something and see how you do. If you don't do well, you move to the second or the third line. This is appropriate for most patients. But sometimes we miss people that don't do well because we don't follow them close enough. We don't do frequent enough MRIs. So they're good, but we have to be very proactive and say, okay, we need to follow you closely. Obviously, with the MS clinics in Canada are getting, it's getting complicated with not enough doctors and nurses to see patients, so sometimes we don't see people as frequent as we should. And the second approach, I sort of talked about this earlier, is if you're not doing well from the get-go, we know that you probably have to use a big gun from the beginning. Instead of like, oh, we know that you're going to have bad MS, but let's start with the first line. We hit early and hard. But that's, it's complicated because it depends on how much of a gambler you are. I ask patients the first visit, oh, are you a gambler? And they look at me like, whoa, okay, what is? And depending on how much of a risk taker you are, some people will say, oh, you know what, these stronger medications, I don't want to do them. I'd rather stick to the ones that, are safe, they've been around. So depending on how much of a risk taker you are going to be more open to more riskier medication. And the same thing with doctors. Some doctors are like, whoa, I don't want to go into these big guns. I'm not used to it. So that also is important. You have to find a common ground with the patient, how much of a risk taker you are and how much the doctor is gonna sort of offer you. So they've done studies that say that usually patients are more aggressive in medications than doctors, which sounds kind of, we're sort of holding on and we don't say, oh, the options are this. So most patients want more aggressive treatment if that's gonna be a better gain. But it's very personal. Obviously, coverage is a big issue. So the stronger the medication, the newer the medication, most insurance company will not cover it unless you go through the sort of failure. You go first, second, and third. They would not go for, okay, let's do the big gun first. So that's still a big issue. If you are with the government, with Trillium always lags behind in what they cover and what they don't. So that's also a big hassle. Depending where you live, unfortunately, you're going to have issues with what drugs can you choose. If your MS clinic or your MS doctor works with a hematologist that can give you the chemotherapy, you're going to have options for that. If you live in a smaller community or someone that is not very familiar with that, you're not going to have those options. So depending on where you live, you're also going to have sort of different options available to you. I was going to put a casino here, but it was a bit too much. And to recap, so the first line drugs are the injectables and the Tecfidera and Myalgia, which are two oral medications. Second line, Gilenya, Tysabri, and Lemtrada. Lemtrada, it's second line, third line. However, in Europe, it's considered first line. So they sort of use the big gun approach from the beginning, which we're kind of behind on that boat in Canada. We're kind of, we use it when things fail, and depending if you have drug if you have coverage, private coverage or not. So hopefully it's coming to the private, to the government funding. Is probably, hopefully will come soon that, one of the most potent drugs available, hopefully it's going to be open for more people if you don't have drug coverage. And again, a lot of things going on with research. Very, very reassuring that we may find something that really, really treats or even cure MS. So what's the risk of not switching? So as I said before, MS is very sneaky. So even if you find that you're doing well, that you're not having big attacks, the inflammation and the damage accumulates over time. So you can have perfectly normal exam, no relapses, but your MRI looks quite striking in the sense that you have newer lesions popping. That's not good. So we have to be kind of on top of where we are and follow you closely, mostly in the first 5 years, because we know that roughly that's when the medications work the best. Oops. Wow. Sorry. So this is a bit of MS. What is MS? So MS is a mix of degeneration, which means damage that will start early on and was going to increase, and the inflammation. So we know that the drugs are more potent in this early stage where the inflammation is really, really present. And we try to move this other stage with the medication. So as long as we can capture your MS earlier, we have more chances of delaying this progression or disability. And the more, if you go into the relapsing and the transitional secondary progressive, the chances of the medications working is less. Because unfortunately, as I said before, we don't have anything for this part of MS. The slowly getting worse, the damage, the neurons getting shrunken, so we don't have anything for that. Hopefully, stem cells or a new drug could do that, but for now, mostly we have to focus on the part that we can do. And so one important thing to remember, so repair mechanisms worsen over time. So it's very common that at the beginning you have an attack and you completely recover. So that's why people are very hesitant at the beginning. I'm perfectly fine, I'm 100%, I recover completely from my attack. But the second attack may not be that fortunate. You may, at the beginning, you probably recover well, but 30%, 50%, you get these souvenirs of the issues. And again, sneaky, very sneaky. MS, we know that even without symptoms, without attacks, if the MRI, usually we do MRIs to follow you. If the MRI looks more active, we see more lesions, that means that the medication that you're taking is not enough to hold your disease. So unfortunately, we don't have a cure for MS yet, but it's a very treatable disease, which, obviously you would like something that works today and not in 20 years or 5 years or whatever. But 25 years ago, we didn't have any treatment, right? So it's a very treatable disease. And most people with MS do well. And again, there's a lot of things. We're doing a lot of research, and we may find things that really, really work with less side effects than the medications that we have now, and with more time to heal and prevent the slowly getting worse. And I think that's it. Did I talk too fast? Probably. No?
So we have one question from the back in this room.
Okay. Hi there. So you mentioned Canada has the highest rate of MS, and I was just trying to understand, is there any Do you know why that is, by any
This
chance?
is no, it's
No,
not.
nothing?
So it's a combination of genes and a combination of probably vitamin D, sun exposure. So we don't know what causes MS exactly, but we believe that those things are the most important factors. People of Northern European descent, Canada, Scandinavia, Northern Europe have more MS than people that live in Southern Europe and in the equator. So it's that mix of genes, mix of sun exposure. So we know that if, let's say, you lived in a country with low risk of MS, like Africa. In Ottawa, we have a lot of Somali patients that have come before age 15. So if you move from a low-risk country to a high-risk country like Canada, before 15, you acquire the risk of having MS that a Canadian would have. So is that even your genes, you're African, Somali, but you moved to Canada, so is that the sun exposure, vitamin D? We don't know. The Inuit, to give another example, so Inuit, even though they live in the northern part of country when they don't get any sun, or I shouldn't say any, but much less sun, they would have no MS. Why is that? Is that a combination of genes? Is it the whale, fat that they eat in their regular diets that has a lot of vitamin D? So we don't know. It's a very interesting thing. Equator people, right? Why people in the equator have less MS? Probably the sun. That answers your question?
No, it does. Thank you. And then just one more.
Yes.
So you had mentioned that there is a possibility that sometimes people can have a misdiagnosis. So I'm just wondering how that's possible and what is 100%? Like what diagnosis? Like is it the MRI that would provide you with that 100%?
So no. So also it's MS. It's like a puzzle. So we put your symptoms, your age. Most people will have MS when they are 20 to 40 years old, and we also have MS MS in kids and after 50. But so your age is important, your symptoms are important, and obviously many times we need to do the spinal tap to say, okay, is this the spinal tap? It looks like MS or not, and the MRI too. So sometimes if it's clear cut, you have an attack, 2 attacks. MRI looks perfect. We don't need to do the spinal tap. But when things are a bit, maybe, first attack with an MRI that doesn't look compelling, we need to sort of do the spinal tap. So 100%, many times we're confident that that's where you are, but sometimes we tell the patients, you know what, we think even your spinal tap is negative. We think that the chances of you having MS are 95. Are you okay with that? I think. And depending on the patients are like, I want 100%. Unfortunately, there's no 100% certainty in anything, but we try to work with the chances or with those numbers.
Okay.
So actually, thank you. That's a good segue into the question that I have here. Without going into the 2 pages, sorry for the one who gave it to me, a lot of different intermittent symptoms that occurred in an individual, a young woman. Doctor refuses, though, to give a diagnosis of MS, though it was suggested that she may have had an MS attack back in May of this year. Mm-hmm. MRI showing lesions, memory issues, but really frustrated for 2 reasons: not being given a definite diagnosis, and then therefore not being put on to one of the disease-modifying therapies, and with the fear that because it's been a slow process, then is that holding back on the wellness that she could experience?
Yes. So sometimes, depending on how typical your symptoms are, we're more confident that it is MS or not. Sometimes people with MS can have weird or infrequent symptoms, but there's also, what else could it be, right? Sometimes we're like, oh, this looks like MS, it's not a stroke, it's not a brain tumor, it's not a Lyme disease, it's not an infection. So there's no better explanation of what you have. And that sometimes we're stuck with that. We're like, this is not a stroke, this is not all those things. Lyme disease is a popular one recently. So we don't have a better explanation. Young, female, living in Canada with weird symptoms. You probably have MS. Can we prove that you have MS? We may not be able to prove it 100%. but sometimes we have to live with the uncertainty, and I'm not sure if this patient in particular has spinal tap or repeated MRIs over time to see if there's any changes on that. So sometimes we follow people, say, oh, we're not sure if you have MS, let's do another MRI in 6-9 months, see what's going on, let's examine you and see if there's any change.
So the benefit, though, in this type of situation of getting maybe a second opinion, if you need to, from another doctor?
Yes.
Okay. What's the difference then between the disease-modifying therapies and stem cell research? Can you speak to that at all?
So stem cell research is a very preliminary trial with therapy, so we don't know if it works. So in medicine, you have different tiers of research. You first start with something that you know, oh, this looks promising, but we don't know if it works. So you start with animal models first, and then you move to healthy people. You move sort of in the Frankenstein ladder to say, we're going to do research first with animals, then with people. So we don't know if it works. It looks very promising. So we have 4 stages of research: phase 1, second, and 3 and 4. So stem cell is in the second phase, which means that looks promising. We are pretty sure that it's safe, and that's why we're going ahead with more trials. But we don't know if it works. So it's not a efficacy. We don't know if it works right now.
Thank you. I'm going to do one question from the web, and then we're going to go back to the room. So I was recently diagnosed and seeing a neurologist, but would you recommend being referred to a clinic such as the London Clinic? So I think the question is more, should you be seeing a specialist at one of the clinics rather than a neurologist in the community?
Yes, so that depends. There's some community neurologists, and actually in the GTA area, there's some neurologists, community neurologists that know more MS than any MS clinic. So depending on how comfortable your MS doctor is with MS, that's where you sort of know if better to go to a MS clinic or not. Sometimes what I find, people get very, always have they second guess themselves. I'm like, oh, maybe I should go to the MS clinic. Sometimes, we may see you once and say, your doctor is doing a good job. We don't need, your doctor can follow you locally, and that's okay. So you don't need to go to a main MS clinic. So logistically, it's not possible. Depending on where you live, the closest MS clinic could be 600 kilometers. So is that worthwhile for you to come? We have many patients that come all the way to Ottawa, from Sudbury, North Bay, Kapuskasing, because, they like to come. Sometimes we tell them, don't stick to your local neurologist, but they want to come once a year, and then the local neurologist will follow them, and that's okay too.
Okay, in the front row here in the room.
Hi, thank you for being here and for giving us all the benefit of your wisdom. You mentioned a number of drugs that are on the verge of being available, and I'm wondering how do the menu of drugs that are available in Canada differ, and treatments differ from others that may be available? How representative are we relative to the rest of the world in terms
Canada?
of availability and treatments? And are we leading the pack? Are we
So
somewhat behind?
we're leading the pack, but depends on, again, so that would be an advantage of being close or being followed in an MS clinic, right? Because we always have like the new drug coming. Oh, this is the new kid in town, this may work. So people say, you know what, I want to try this drug. It looks very promising, and that's how people want to really participate, and that would be an option. So Canada is a world leader in MS. And actually, we are the world leaders probably with other groups in bone marrow transplant, which is very exciting, and we've seen amazing results. So the Ottawa Clinic in Canada is one of the world renowned places to have a bone marrow transplant in that sense. So we are very ahead of the game.
Does that answer your question? Thank you. We're going to go to the back in a minute, Amy, but I just have a question here then. The concern is that an individual diagnosed at the age of 26, now 28, also has fibromyalgia, and the concern is related to the fatigue that she is experiencing, which is quite debilitating in her situation. Can you speak a little bit about how to battle fatigue?
Yes. So funny that you say that. So fibromyalgia is common but orphan disease. So most people don't believe that fibromyalgia exists. So rheumatologists probably are the ones that think that exists. Neurologists, depending on your training, if you're old school, you don't believe it doesn't exist, but it does exist. And actually, they can have symptoms that are very similar. I have so many people that come to the clinic and say, oh, I have MS, and we tell them you have fibromyalgia. And on the other side, we have many patients that have MS, and they have fibromyalgia. It's very common disease to have if you have MS. So for MS fatigue, MS fatigue is very tricky to treat. Is it related to depression? Are you depressed? So that's the first thing that we kind of, how much is fatigue? How much is depression? How much is pain? How much your medications for pain are making you sleepy or the side effects? How much, it's the medication? Are you diabetic? Do you have a thyroid problem? So are you anemic? So other issues also play into the fatigue. So there's we tell patients to start with, I always tell my patients, how much water do you drink? And they're like, yeah, okay. They don't drink enough water. So the first stage is drink lots of water. MS patients are very sensitive to dehydration and being overheated. So lots of water. Be smart. When you have more energy, you do things that are more energy consuming. Try to. So the non-pharmacological issues are probably very important and need to be also done on top of the medication. Medications. Amantadine, Allertec. Sometimes we use Ritalin, very rarely, but sometimes it's a bit off-label, but we have used Ritalin for MS fatigue, and sometimes it works. Or antidepressants. Some antidepressants are good for fatigue in the sense, obviously, if you are depressed, not only for the fatigue. So if you are a bit depressed, we'll give you some antidepressant that has a good sort of effect on fatigue as well.
Fatigue is a topic in itself.
Yes.
That I know the
Yes.
MS Society has definitely addressed in the past, so we can watch our websites for that, because I believe we have some information on it, but definitely some books at the back.
Yes.
We have a question here, this gentleman, and then I have another question, crazily enough, about fibromyalgia again.
I'm the expert in fibromyalgia, I tell you.
Great. Go ahead, sir.
Hi there. I got a couple of questions that have come
Yes.
up. They're corollary to those. The first one is the geographic study is pretty clear that 15, if the age of 15. Why don't we have a policy that kids under 15 are getting vitamin D through our family
Yes.
physicians?
That's a very good point.
It puzzles me to
Yeah.
no end that we have the focus on treating, but the whole prevention thing, when it seems like it is an accepted potential cause, the lack of vitamin D.
True.
It seems to me that our grandchildren should be
Yes.
should be getting vitamin D, and I really don't see much of that in the.
So we recommend actually all our patients, give vitamin D to your kids
Yeah,
because
okay.
it may be protective for MS and
Yeah.
protective for other autoimmune problems and even cancer.
Yeah.
So it's a very good, that doesn't have side effects. We all probably should have it because we go bananas in the winter with cabin fever, seasonal affective disorder. So everyone in Canada should take vitamin D.
Yeah,
So the downside is nothing.
So if our family physicians aren't on it, we should be telling them to get with the picture.
Yes.
Yeah. Okay. The second question is a couple of the slides back was just one bullet on repair mechanisms. What are they? And I know the stem cell is about the repair, and I'm really interested in the whole demyelination thing and the cholesterol link.
No, cholesterol, yeah.
Yeah. I was on statins for 15 years prior to, and I know it's not cause, but I'm just wondering if there's some sort of link there. But the repair mechanism is what I'm really interested in. That I'm using a food approach, which I know you were going to talk
Yes,
about a little
yes,
bit
and we can talk, yeah.
about that. But and that's clearly about repair. And I'm just wondering what
Yes.
the science is telling us.
So the science
so
is
far
so that's the holy grail, right? So we want something, so we know that MS is an inflammatory disease, but it's also a degenerative disease. Unfortunately, we have not found something that works on that sort of degeneration. So we don't know. Stem cells could be the solution, maybe some other drug will sort of try to repair. So we know that we all have repair mechanisms in our brain. Well, obviously, when we're younger, those work better. When you're older, those are worse. Our brain shrinks every year. Even if we don't want to, even if we don't have MS, our brain's going to shrink. So the repair mechanisms, we don't know exactly how to target those. That's the holy grail of MS therapy, for sure. And the statins, yeah, we always trying, different drugs. Maybe we tried like crazy things, acne medication, is that right? So why not? It's well tolerated, the statins. We may have a big sort of development in the next 5 years with something that is completely unrelated.
Thank you, sir, for your questions. In regards to back to MS and fibromyalgia, how can you tell the difference between the symptoms?
So very tricky. So you have to see people with fibromyalgia a lot to try to sort of, they all look the same. So let's put the other way. So if you don't have MS, fibromyalgia can mimic MS, but obviously you don't have, your reflexes are not brisky, so other signs will tell us that probably it's only fibromyalgia, it's not MS. So fibromyalgia, unfortunately, it's, so tender points, not sure if you guys know, so fibromyalgia causes a lot of muscle pain, joint pain, which usually MS doesn't cause. So that's a bit of a, if you're having a lot of muscle pain or joint pain, MS usually doesn't cause that. So that's more fibromyalgia. Pain can get tricky because both are painful conditions. Fatigue, the same thing. Even like people with fibromyalgia can have relapses, which means that for a couple of weeks or a couple of days they are like completely out, but then they recover. So that also can mimic MS relapses. It's very, very tricky to tell them apart.
Thank you. What is the best way to communicate with your neurologist about your symptoms? This gentleman finds that the neurologist is quite dismissive of symptoms and that he feels is important to himself. I feel this impacts the effectiveness of the medication that he's on, in this case Tysabri, and his EDSS score. So how do you talk to your doctor about your symptoms?
Yeah, so that's, it's a long, I like MS because it's a long, life relationship. We get to know each other. You know me, I know you. So it has to be like a back and forth. So unfortunately, we sometimes, don't have time to, oh yeah, that's nothing. So everything is important. We need to address those. But I find like older neurologists sometimes are a bit more dismissive of like, yeah, if you're not, sucking a wound in your chest, that's fine. Sometimes we, like perception, it's like it's bad, not so bad, but we have to address all the issues. So it's very important that you do have a good relationship, and if you feel dismissed, that's not a good way to start. So maybe you should, going back to the availability of neurologists around, you want to switch, you want to go to someone else that you feel more kind of heard, right?
Sounds good. Gentleman at the front of the room. So we're back in the room. Thank you, Nikki.
Oh, yeah, I have a question.
Yes.
Yes, my name's Howard, and I had diagnosis about January 2014, so it's fairly recent. And interestingly, it was the first person to mention to me was the receptionist for the chiropractor where I was being treated for whiplash, who said that some of the symptoms that I was experiencing weren't typical for whiplash because I had some numbness in my abdomen and in my front thighs. So that was kind of unusual.
That's smart
Yeah,
receptionist.
it was very perceptive. And the question I posed to the specialist, I'll give you the same question because I asked, did the auto accident precipitate the MS coming on, because I was already over 50, and like you said, it's not usual to,
Yeah.
right? So come on. So he said, oh no, the accident, the whiplash had nothing to do with the onset of MS. But he also said, we don't know, like you're saying, we don't know the real cause of MS. So if you don't know the cause, I asked, then how can you tell me the accident didn't cause it?
True.
So
So,
that's my question.
Yeah, so late onset MS is rare, 2%, but probably it's higher. Sometimes can be clouded by, oh, you know, you have hypertension, you probably are having stroke instead of MS. So we know that exists, and actually it's getting more frequent, and we know more about MS in later ages, so we know that exists. Coming to the second question, did the whiplash cause MS? Evidence, we should say no. However, as you very well said it, we don't know. It may have, right? On the other hand, so many people with whiplash will be seeing more MS on people that had accidents or even, you know, other back injuries, where we see more MS developing after those.
Right.
So no, the evidence says no, but we don't know exactly.
Because I attended a mindfulness meditation class at St. Mike's where Dr. Selchin, who's the neurologist who diagnosed it finally, and what I noticed in this, it wasn't a large class, but in a class of about 10 of us, every person had at least 2 major life events that, I mean, in my case, I had a car accident and I had a couple other things happen.
Yeah.
I work for the post office, so, you know. But I noticed everyone in the meditation class did have, they'd lost their job, they'd lost their marriage or something. It happened more than just the usual.
True.
And that their MS came on after those events. So I was wondering if there's some link to that.
Yeah, so stress, over the years, we find out that a lot of studies that stress does not trigger MS. However, we don't know enough. So there's this new discipline called neuroimmunoendocrinology, right? It's like, oh, your hormones are out of whack, your mood is out of whack, and that may impact on your brain and your brain. So maybe, you know, if we will know that in 20 years that stress, a big stress, will trigger MS. Now we have to say no, but we don't know enough about MS. It's interesting that you say that. It's very
Good
common
questions.
that.
Thank you.
Great question. Thank you, Howard,
Thank
very
you.
much. So here is another question from the floor that I was given that is a topic in itself, Doctor. Cognitive issues in MS. Can you maybe speak to a few points?
Yes.
And then I can also refer this individual to our websites that have quite a bit of other information.
Sure. So cognitive problems in MS are very common, and even in early MS, you can have a lot of issues. Unfortunately, we don't assess well for cognitive problems because we don't have time. Sometimes they are mild, and we don't have the tools or the tools to pick it up. But we know that it's very prevalent. 30% in early MS, up to 60% in people with relapse and remitting or secondary progressive MS. So it's very, very common. Usually causes issues with multitasking, issues with speed of processing, memory, short-term memory more than anything, but we don't have the tools to measure it. Unfortunately, the neurocognitive assessment is very expensive. If you will have, you know, usually costs $1,500. The government doesn't cover it. Only if you're admitted in a neurology ward, you will have that covered. But anyone, if you say, oh, you know, I'm struggling at work, they usually have to pay it out of pocket. Most insurance will cover 80%, but if you don't have an insurance, most people can afford $1,500 to say where the issues are. Is it very helpful? Sometimes we, depending if you're still working, if those issues are very, very striking, we usually tell patients, you know, it's going to be a good thing that you have that because they can pinpoint exactly where the issues are. They're testing that takes 8 hours, 10 hours, and they're very detailed. So they can help you say, okay, your issues are here, but your strengths are in these other domains. So they can give you tips to sort of compensate for the issues. But unfortunately, it's not available or covered. So that's a big, big issue.
Thank you. Just to remind the people online, please get your questions in and we'll refer to them. We have a question at the back of the room, then I'm going to go back to one more here.
I'm asking a question about Lemtrada. I noticed it was a second line and third line.
Yes.
Why?
So actually, so in Europe it's first line, actually. Because we know, we know that going to the models of treatment, if you hit early and hard, you're going to have probably a better outcome in the end. So coverage, sometimes, Health Canada, so it's different countries have different regulations. In Europe, many European countries is first line. In Germany it's first line, in the UK it's first line, but in Canada it's second line, sometimes third line, which is very unfortunate. Depending on the insurance, we can say, okay, it's second line or third line. Sometimes people, we would like to give first line Lemtrada. I have a 19-year-old that I diagnosed a month ago that didn't have an insurance, so we are giving her chemo. So talking to the mother, saying, oh, you know what, your kid is not going to be able to have kids, when we could have used Lemtrada to sort of save her. So it's crazy. So sometimes the coverage issue, the money gets in the way, regulations, so every country is different with that.
Different provinces are different too.
Exactly. Which is very unfortunate. So in Ottawa, we live in the sort of across the river, you're in Quebec, here you're in Ottawa. So sometimes you're tempted to tell patients, you know what, get a little apartment in the Quebec side because they're more open to like the bigger guns. You know what, it's the bridge. So, yes.
Thank you for your question. Is there any specific diet for MS?
Good, we're coming back to the diet.
Oh, we're getting to the diet.
That's good. So, no, but can we prove it? Probably not. So the big fad diets are gluten-free, dairy-free, and now in sort of out west is the paleo diet. That's the big new thing. So there's no evidence that diet will help with the inflammation. So probably it helps with inflammation in your gut, but not in your brain. Is it harmful? Probably it's not harmful. It's a pain to do. So people with no gluten is very restrictive diet. So that's more expensive. So if your family, if you're having specific diets, all the other part of the family, it's different. So it's a very complicated to continue. But is that harmful? Maybe it'll be good. People swear by it, feel very good on gluten-free and dairy-free. The dairy-free, it's always kind of makes me a bit uncomfortable because we need dairy. We need calcium for your bones. So dairy-free, it's a bit, but again, people swear by it and they feel really good. So it may have an impact in 10 years. It's not harmful, the same as vitamin D, do it.
So you're speaking about some of the fad diets, not fad, I shouldn't use that word.
Yeah.
But some of the diets that are out there that people have tried regardless of MS or not. But is there anything that the individual should be eating if they have MS or should not be eating?
Yes. So,
or ingesting?
Yeah. So
or we can
no.
add that to smoking and everything else. Let's throw it all together.
So no. So obviously it's good to be healthy, had a balanced diet, but no specific foods in particular. However, one big trend is like foods with antioxidants, with a lot of antioxidants, right? Sure. If they're not helpful, they're not harmful, so they may have an impact on the long run, sure. I don't like when we kind of try to replace the diet with a mainstream treatment. If you do it in combination, sure, but not, I would not replace it as a main treatment. So smoking, we know that people that have MS and smoke do unfortunately worse than people that don't smoke. So marijuana is good for certain symptoms, but now we're getting more information that it may be harmful for the brain and cognition overall. Yeah.
Thank you. We have a question at the back, and then we'll come back up to the middle. Yes, Carlo.
Yes. Hi. Well, you know my name, yes,
Carl.
Thank you. Dr. Rush, your slides were very clear. It's just the last few slides, there was a title at the top, risk of not switching.
Yes.
I did not understand. I lost that. What did you mean, risk of not switching?
Yeah, so if you're on a medication, right, and you're still having attacks or your MRI looks that you're having more lesions with the previous one.
Yeah.
So do you stick to that, or we need to move on? Now we know that there's options, right? So if one is not working, there's other options that may really work for you. And everyone is different. So first line, second line, third line. So the risk of not switching is that your MS is sneaking without, sort of you're losing time and you're accumulating damage.
Without any
Yes,
success.
exactly. And
Well-
sometimes going back, so there's some, I shouldn't say old neurologists, but some neurologists are like, yeah, one little attack, not a big deal. But what's a bad attack? That means that there's something brewing. We have medications that can really stop the disease. So if you having attacks on medication, that's a red flag. So we always consider switching up or switching to a different medication in that same line.
Okay. Well, I've been taking Copaxone for 5 years, and before that, 5 years on Rebif.
Okay?
So that's both first line, right?
Yes.
So my attacks are not so dramatic. It's been a steady downhill progression, except 26 years ago, I guess I had the CIS that you described.
Okay.
I lost vision of my left eye for 1 week and nothing for 10 years. And then I get the foot drop, and I think that's when they made the connection that
I see.
that it's MS, but I switched medications, but perhaps, according to what you say, maybe I should have gone to a second line. After 5 years of Rebif, maybe
Yeah.
I should have went to second line.
Yeah, but 5 years ago, you were, the only second line was Tysabri,
Oh.
so we didn't have the other second lines, or the chemotherapy, right? So some people are, whoa, chemotherapy, and depending on where you are, right? If you had the first symptoms way back, so maybe your the inflammation is not that prominent, but all the other degeneration, the damage, the slowly going worse, it's more prominent. So even if we switch you to the biggest gun ever, we may not have any impact on the slowly getting worse. Because you had MS for what?
26 years.
Yeah, right? So probably you are kind of transitioning into the secondary progressive phase. Where
I
we,
am, yeah.
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 But we don't have much, unfortunately, we don't have anything to target that phase. But
Yes,
we didn't have any other things 5 years ago, so don't think that, sometimes, depending on where you, when.
I think I'm going to be taken off of immune modulatory therapy, like perhaps Trillium drug program won't cover it anymore
Yes.
because my EDSS is like 5.5.
So actually, that's a very good segue, if I can, into the next question, Carlo, is why is it that the government doesn't cover medications? Is it related to the EDSS? Is it related to the costs of these drugs? These drugs are expensive for the patient, so why
Yes.
are they not being covered?
Yeah, so depending on where you are, so usually they would not cover MS drugs if the number is, depending on the drug, 5.5 or 6, because we know that usually people get to that point sort of in the secondary progressive phase. So when we know that the medications don't do anything. So that's why we're like, oh, why, subject you to the treatment with the cost that it implies if they're not going to do anything for the slowly going down. That's for the secondary progressive. So the coverage issues are very specific for different drugs and different provinces, as we said before. So that has no rhyme or reason, and the government always lags behind, and the criteria for government coverage are very strict. So it's hard sometimes to move up in the ladder. Hopefully, they're going to get more, they're going to know, right? So young people, why go to a toxic medication if this medication will have, much more impact, and it's going to save you money in the long run. So governments, bureaucrats, sometimes they don't care about, patients, and they only care about teaching the money. This costs 30,000, this one costs 100,000. So unfortunately,
And the role of the MS Society, as you probably are aware, we do have government relations that do look at these concerns and do present the case
Yes.
before the various parties. Gentleman in the middle.
I have two questions. One, when you talked about late onset, what does late mean?
So older than 50,
50.
yes,
And is MS, ADEM, and NMO mutually exclusive?
yes. Because now we have markers, ADEM not as much, but NMO, yes, because we have a marker in the blood and the spinal fluid, and the features are different. So yes, you shouldn't. I think there's one case which probably it's that I have both MS and NMO, but there's a lot of spectrum. Usually kids have like NMO, ADEM, and now there's a new condition called anti-MOG, that it may be a in-between entity. So we're learning more about other demyelinating disorders that may be, in between those.
Okay. Sorry, it looks like I've missed a couple of questions that were online. I apologize. Why are the rates of MS higher for females in Canada than anywhere else?
Yeah, that's another question that we don't know how to answer. Hormones may play a role, but we don't know what that happens. And actually has changed. In Canada, 25 years ago it was 2.1 to 1, and now it's 3. So we don't know what in Canada has changed.
Okay, I have a very long question here, and I do apologize to the person online. It's regarding long-term insurance, life insurance, critical care insurance, et cetera. And I actually do have something on our website
Yes.
that we can refer you to in regards to life insurance. But the bottom of the question, which goes on and on about specifically, is the concern that the insurance company, it looks like, might be denying the siblings of the individual diagnosed with MS because of the chance of
Oh my God,
heredity.
that's ridiculous.
So the question is that, what's your opinion? It's ridiculous.
That's
So touch-
ridiculous, yes. So unfortunately, again, insurance companies are scoundrels, so they always want not to pay, basically. So they're like ridiculous. So and in the last couple of months, I've been, dealing with all these ridiculous cases. So it's crazy. So you should not be denied. The unfortunate thing is, even if you don't have MS, if you see a specialist, if you see a neurologist, you're done, which is crazy. So that's one thing. I had the issue a couple of months ago, 2 times actually, with critical illness insurance. That should not be denied under any circumstances. If you pay for it, it doesn't matter. Even if you're doing perfect with the MS. There was this poor military guy that was doing well with MS on treatment, but he was denied. He was paying like, I don't know how many millions of dollars, and they deny it because, your EDSS is 0, so you're too good. So no, that's for disability, sure. But the critical care, you should not be declined on any circumstances. And the fact that you have MS doesn't mean that you're going to have MS.
Thank you. And so if I have missed up on any of these questions, just email me directly at angela.covert@mssociety.ca, and I will try to make sure we get the accurate question. How much, let's do this one first. Have you looked at the MS at the cellular level, like the mitochondria functioning?
Yes. Yeah.
Can you speak to mitochondria functioning?
Yes. So we are looking for, more information about MS. Now, maybe that will help us to know who's going to do well on each medication. Is it, now we have the proteomics, which means that we dissect all your genes, and we're like, okay, you have more of this protein, more of this, and you may do well with other medication. The same thing with the cellular level. Looks promising, but we won't probably have an answer in many years, which I know it's, for you, science sometimes is like 20 years. So we're looking at it, but we don't know any sort of thing that may help.
Okay, thank you. Any more questions in the room before I deal with this last one? Okay, so there's one right in front. Thank you, Nikki.
Thank you. So we've talked quite a bit about Canada, highest rate, large selection and a good choice of meds and therapies. But straight up, there's no cause, there's no cure. it's expensive, whether it's drugs, whether it's individuals like yourself and high salaries, no offense, we love you for being here, okay? But let's talk, if you can, on worldwide. Okay, it's a worldwide issue, even if it's only 1 per 10,000 where you're from, or it's higher here. MS Society of Canada is great, but let's talk about worldwide. How are we collaborating the efforts so that maybe Canada's focusing on something, US is focusing on something, Europe's focusing on something? Can you touch on what's going on? Because, you know, it's the old expression, 100 people dealing with something is better than everybody doing stuff individually. So kind of just touch on that if you can.
So
thank you.
Actually, we are collaborating with other people around the world now, you know, with email and, you know, technology. We are doing that, and it's very productive. So depending on where you live, there's some different interests. So some people in Poland, they're doing this, you know, weird like patches with certain proteins that may help with MS. So they're doing that and looks promising. So depending where you are in the world, actually the Argentina group is one of the worldwide in parasites and MS. If parasites are protective for MS or not, we believe that they may be. So different areas of the world will focus on their own kind of idea of what causes MS in those countries. So we're doing a lot of collaboration. Hormones. Hormones are good, bad. Fertility treatments. There's parts of the world that have more sort of expertise in different areas. So we're doing a lot of different things worldwide. Actually, there's a lot of collaboration.
I'm about to get you the website, though, to the MS Society that speaks to a lot of this research that's happening all over.
I was just going to say, the only thing that I ask is, like, who kind of helps spearhead this? Like I realized, like, is MS Society talking to everybody individually, or is like somebody getting together twice a year saying, okay, you guys focus on this, you guys like help us just kind of understand. It's nice to hear about all this stuff, but can you just touch on that?
Yeah, so so the advantage of MS clinics are, you know, you are in contact with colleagues all around the world. You go to conferences with a new thing. So if you're attached to a MS clinic, you have more sort of information of what's going on, of the new advances. So in that sense, we tell our patients, you know, we don't know these things, maybe coming. So but there's a lot of, so ECTRIMS is one of the biggest meetings in MS.
And ECTRIMS stands for?
For European Consortium of
something MS.
MS. So, and usually it's a big conference, it's only MS. So it's 5 days of only MS and all sorts of, you know, we deal with progressive MS, with new treatments. So it's the best conference to attend because you see people from other worlds. You get to know, oh, what are you guys doing? What's your new sort of project? So it's a very good place to network. And as I said before, now with the internet, right? So you're like looking and putting any search, and you're like, you find this guy in Australia. Oh, what do you think? So a lot of, fortunately, technology helps to kind of connect with people around the world. I'm not sure if that answers.
I just don't want to see wasted effort.
No,
True.
For certain. I'm just going to be putting up on the screen right now 2 websites that you can look at what is happening across the world, where Canada is very active, the Progressive Alliance and the Multiple Sclerosis International Federation. So you'll see their websites there. And
I get their emails all the time.
well, there you go. But
I haven't studied it.
No, and you know, you've brought up a very good point that we've had in the past. We have had one of our staff of the MS Society, Dr. Karen Lee, who is the Vice President of Research, who has spoken to these real specific concerns around how research is done. So that is something that we could look at in the new future. You follow her on Twitter, then you probably know more than I do right now. Okay. No, there's lots of exciting stuff going on. Thank you, Doctor. How much DNA testing then for markers has been done in MS research?
So not much, but that's one of the things that we're looking at. So it's very expensive to do. It may not sort of work, but we're doing that. Genes and actually the proteins. Less the small little parts, every protein, so we're checking that. DNA, we don't know. Not yet. There's things going on, but very preliminary, very early on research on that.
So we have now just gone over time a little bit. So for those who are online, if you can bear with us, I think we may have a couple more questions in the room. And I'm just watching if there's anything more online. Other than that, we'll finish up in a few minutes. We're fine here? Okay. Oh, we have
Yes.
a question right up front.
Howard.
Howard.
Did you ever hear Gabor Mate? His book is called When the Body Says No, The Hidden Cost of Stress. Because that's an excellent book. You can pick it up at Chapters or Indigo. And he works in Vancouver. He was writing for the Globe and Mail here, a medical column, and he covers all the different spectrum of what stress ends up causing in the form of illnesses. And he's according to him, he believes the stress is the cause behind a lot of illnesses. But anyway, I just thought I'd mention that book.
But I think what their comment is asked, so the question is begged to be asked is, what if you have MS or a chronic illness, what's the impact of stress
Right.
on that disease, more
Yeah,
so than
thank
the
you.
cause of a disease?
Right.
So what is
True.
the impact of stress on MS?
Thank
So a lot, right? So if you're stressed, we think that it doesn't trigger attacks, but people, if you're stressed, you're going to be sleeping worse, you're not going to be eating well, you're going to be, kind of tense. So all those can impact on fatigue, on pain, on all those things. So obviously, if you're having a horrible time, everything impacts on your MS in your how you feel. So for sure. But how that's kind of mindfulness you mentioned before. So that we know that for everyone, not everyone with MS, not people with MS, but everyone, right? We all have stresses and issues and crazy lives. So mindfulness, to look for something that would take the stress down, that's the biggest thing. Do we have time? Sometimes we don't. We say, oh yeah, the medication, do the medication. Sometimes we need to do a more holistic approach of medication plus, counseling, mindfulness, yoga. I always tell my patients, yoga, Tai Chi, and for fibromyalgia, the same thing. The things that have been proven for fibromyalgia are Tai Chi, yoga, and aquafit. Right? So, and the MS, a lot of evidence that those also are very good because they don't make you tired, they give you energy, your mood gets better. So.
Every time I visit my mom, my symptoms increase.
I don't know if you heard that. Every time he visits his mom. Well,
Yeah, I gave my
don't
mom
wanna
an
go
iPad
there.
and FaceTime. Now she's FaceTiming me every couple of hours. I'm like, not a good idea. Not a good idea.
So Dr. Rush, thank you so very much for being
You're
here in
welcome.
Toronto or Mississauga tonight.
Yes, thank you.
Thank you again, Doctor, and thank you all for being here tonight.